emergency medicine. For those of you I haven't met, my name is Victor, currently a junior doctor working at the Royal Melbourne Hospital. In these virtual ward rounds, I'll endeavour to provide some practical insight into how theory learnt from medical textbooks can be used to solve real-world clinical problems. As in previous lectures, I'll take you through 3 interesting cases and use them as a stimulus to talk about some important clinical concepts pertinent to any emergency medicine rotation. So, as you're no doubt aware, the Virtual World Round series is brought to you by Teaching for Impact, a not-for-profit organisation with a mission to use education as a weapon to create meaningful social impact. This year, all of our medicine lectures, including this one and the one run by Jason Dong and the preclinical exam revision lectures, are all being run as fundraising events for the Asylum Seeker Resource Centre, the largest independent human rights organisation for people seeking asylum in Australia. We as an organisation share ASRC's belief that all asylum seekers deserve protection, respect and a chance to rebuild their lives, and invite medical students across the state and nation to join us in our campaign to make a meaningful contribution towards this worthy cause. So for those of you who are interested in keeping abreast of the tutorials and lectures that our dedicated TFI Medicine team has to offer, scan the QR code on the right. And as always, I want to keep these sessions relatively informal. At certain points, I'll put some questions to the floor, and I'll love it if all of you could contribute answers either to the online chat or, better yet, unmute and share your thoughts with the wider group, as learning is always more fun and effective as a dialogue rather than as a monologue. So without further ado, let's get cracking. So for this lecture, I want you guys to imagine yourself as a junior doctor working in a busy emergency department under the supervision of an ED consultant, otherwise known as a FACEM, who will pick patients for you to see. And your job is to take a history from the patient, perform an examination, work out what you think is causing the patient's presentation, have a think about what the next steps in management should be, and then run all of the above by the FACEM before actioning the plan. So the first patient that the FACEM assigns you to is Mrs. MN. So she's a 64-year-old female presenting with non-specific upper abdominal pain. Now, before seeing the patient, you perform a thorough chart review and find the following information about the patient's background. So the patient has quite an extensive past medical history. She's a type 2 diabetic, has cirrhosis secondary to non-alcoholic steatohepatitis, has hypertension, hypercholesterolemia, GORD, gout, depression, back pain. She's previously had shockwave lithotripsy and a stent inserted for kidney stones. She's had a previous cholecystectomy and had laparoscopic banding procedure done in the past as well. Those are her list of medications. She's from home with her husband and daughter, works in customer service, is a non-smoker and a non-drinker. So before we go and actually talk to the patient and delve a bit deeper into the history, anyone have any preliminary thoughts on what could be driving her abdominal pain, bearing in mind her medical history? So feel free to unmute and share your thoughts with the group, or just use the chat function. Yeah, perforated ulcer, fantastic. I'm not familiar with the differential that Wai Chung has suggested, but worsening cirrhosis, yeah, maybe. Thinking upper GI, stomach, liver, duodenum, lower esophagus, fantastic. Variceal bleeding, yep. Pancreas, fantastic. Psych-related if non-specific, yep. Probably a diagnosis of exclusion. Any potential, yep, small bowel obstruction, fantastic. Any differentials that you think might be more, I mean, like all of those are pertinent to the case, but I guess any differentials that you think this patient might be at increased risk of having, given her past medical history? A bit of a stretch, but AMI or pneumonia? Yeah, certainly. GIT upset due to medications, aortic dissection. Fantastic. Okay, great. So I want to point out a few things in her past medical history. So she's a type 2 diabetic on a combination of saxagliptin and metformin. Now, can someone remind me what saxagliptin is? What class of agents does saxagliptin belong to? DPP4 inhibitors, fantastic, and metformin. She's on empagliflozin as well. What class of drugs is empagliflozin from? Sglt2 inhibitors, fantastic, and exenatide as well. So she's on quite a few agents, although she's not yet insulin dependent. So it seems to suggest to me that her type 2 diabetes is fairly not well controlled. So I guess, you know, something that we would want to rule out is a side effect of empagliflozin. Does anyone know what serious side effect is associated with SGLT2 inhibitor use, particularly in the inpatient setting or in the setting of an acute illness? Yeah, HHS or DKA. So yeah. So you're classically taught that HHS is associated with type 2 diabetes, whereas DKA is associated with type 1. DKA can certainly occur in type 2 diabetes as well, especially type 2 diabetics on SGLT2 inhibitors. So SGLT2 inhibitors cause a particular variant of diabetic ketoacidosis called euglycemic Dka. And we'll talk a little more about that. And DKA can certainly cause abdominal pain. So certainly I'll be interested in looking at this patient's BSLs, ketones, and also, you know, a blood gas, either a VBG or an ABG. I also want to point out that this patient is cirrhotic, and someone commented on this previously as well. So if the patient's cirrhosis, so we don't actually know what, so we grade cirrhosis based on Child-Pugh, you know, classification system. We don't actually have information about how severe the cirrhosis is at the moment. But if the patient's cirrhosis is complicated by portal hypertension or ascites, the patient could be presenting with a complication of ascites called spontaneous bacterial peritonitis, or secondary to portal hypertension could in fact be presenting with massive splenomegaly. That's distending the capsule of the spleen, causing this upper abdominal pain. Sorry, let me just admit a few people first. All right, so that's one differential that I want to rule out. Now, this patient has a past history of kidney stones. It's bad enough that it's needed shockwave lithotripsy and also a stent insertion. So this patient might be, you know, for whatever reason, predisposed to developing nephrolithiasis. So although you know kidney stones classically present with loin to groin pain, this could, you know, very well be a recurrence of kidney stones. We note that this patient has had a cholecystectomy in the past, so doesn't have a gallbladder, so gallstone disease is probably unlikely. Although, you know, in another patient, you know, definitely, you know, biliary disease is something that we need to consider and rule out. Now, the patient has had laparoscopic gastric banding in the past. Does anyone know what gastric banding actually entails and what it's commonly used for? Like what the procedure is done for?
Please.
Yeah, so it's a bariatric procedure. It's actually a fairly outdated bariatric procedure where they, I'll describe it in a little more detail later on, but basically they put a band around the upper part of the stomach, and link it up with a port so that the band, how tight the band is, can be adjusted on the outside, and basically, you want the band to be tight enough to restrict sort of your appetite and food intake, but you don't want it so tight. A common complication of laparoscopic gastric banding is that the band becomes too tight and the patients become dysphagic, which sort of puts them at risk of aspiration pneumonia as well. And worsens gastroesophageal reflux disease. So taking the past medical history into consideration, those are things that you would want to be thinking of. Of course, the patient could be presenting with something that is not directly related to her past medical history. So things like gastritis, as someone said, peptic ulcer disease, pancreatitis. The other.
Why isn't it connecting?
The other one that you could consider is something called, sometimes patients can develop clots in the hepatic vein, and there's an eponymous name for it, and it presents with abdominal pain as well. Does anyone know that eponymous name for hepatic vein thrombosis? Yeah, Budd-Chiari. So Budd-Chiari syndrome can present with abdominal pain. You can also develop clots in the portal vein as well, called portal vein thrombosis. And in this day and age, both Budd-Chiari syndrome and portal vein thrombosis can be associated with, or can be a clinical manifestation of vaccine-induced immune thrombotic thrombocytopenia secondary to AstraZeneca vaccine. So that's also something that you should consider as well when the patient last had their AstraZeneca vaccine. Or it could be something as mundane as gastroenteritis, or it could be an AMI, as someone suggested, since it's upper, localized to the upper abdomen. So bearing all of that in mind, I might just talk through a couple of things. So a quick word about Sglt2 inhibitors. So as we all know, Sglt2 inhibitors are a common oral anti-hypoglycemic agent used to treat type 2 diabetes. So there are currently 3 Sglt2 inhibitors that are available on the PBS. So the first 2 more commonly used than the last one. So dapagliflozin, empagliflozin, and ertigliflozin. So the mechanism of action of Sglt2 inhibitors is essentially in the name. So as we all know, the glomerulus filters around 180 grams of glucose every day. The glucose is then 100% reabsorbed at the proximal tubule. So 90% of this reabsorption occurs in the S1 segment of the proximal. So the proximal tubule is divided into 3 segments. So S1, S2, S3. 90% of the glucose reabsorption occurs at the S1 segment, also called the proximal convoluted tubule through the Sglt2 transporter. And the remaining 10% occurs at the S3 segment of the proximal tubule, or the straight proximal tubule, through the Sglt1 inhibitor, Sglt1 transporter. So Sglt2 inhibitors, it's in the name, it inhibits Sglt2 at the proximal convoluted tubule, or the S1 segment of the proximal tubule, disrupting 90% of glucose reabsorption. The glucose remains in the renal tubule and is peed out. So it promotes glycosuria and glucose loss that way. So you may also be aware that Sglt2 inhibitors are a hot topic at the moment, not just in endocrinology, but in cardiology as well. So there was a recent NEJM paper published at the end of 2019 that showed that Sglt2 inhibitors, specifically dapagliflozin, could decrease the risk of HFrEF, so heart failure with reduced ejection fraction, or death from cardiovascular causes in patients with HFrEF, regardless of whether they have type 2 diabetes or not. So following the publication of this paper, about midway through 2020, the FDA, which is the regulatory body in the US, approved Sglt2 inhibitors for the treatment of HFrEF in adults with or without type 2 diabetes. So this was the first time a drug in a class developed for diabetes was approved for heart failure, even if diabetes wasn't present. So Sglt2 inhibitors are hot topic in cardiology at the moment. Now, Sglt2 inhibitors have a couple of side effects that you should already be familiar with. It's listed on the slide there, but because Sglt2 inhibitors promote glycosuria, and it increases the risk of patients developing UTIs, and it also increases the risk of vulvovaginal candidiasis as well. Now, the glucose, because the glucose isn't reabsorbed, it stays in the renal tubule. The glucose in the renal tubule acts as an osmotic diuretic that draws water into the renal tubule. So Sglt2 inhibitors also cause polyuria, which can result in dehydration, which can result in things like orthostatic hypertension and cause AKIs as well. But probably the most important side effect of Sglt2 inhibitors that you need to know is that it causes euglycemic Dka. So potential triggering factors for Sglt2 inhibitor-induced euglycemic Dka include intercurrent illness, which applies to every patient that is admitted to hospital, reduced food and fluid intake, reduced insulin doses, and a history of alcohol intake. So this is the reason why you will never find and should never find any patient on the ward that is still being given Sglt2 inhibitors in hospital. So it's a policy certainly at Royal Melbourne that when a patient is admitted, if the patient is on Sglt2 inhibitors, we withhold the Sglt2 inhibitors for the duration of their hospital stay because of the risk of euglycemic Dka. So a bit about the pathophysiology of DKA. I'm sure most of you will be already be familiar with the mechanism already. But remember that serum glucose is regulated by two main hormones that are opposing in action, so insulin and glucose. So insulin tries to decrease serum glucose. Glucagon tries to increase serum glucose. So usually what happens after a glucose meal, this serum glucose rises. The glucose enters pancreatic beta cells, resulting in insulin release. The insulin, goes to the liver, decreases glycogenolysis and gluconeogenesis. It also goes to peripheral tissues like skeletal muscle and adipose tissue and increases glucose uptake, so thereby restoring normoglycemia. Insulin also has a number of other actions. So it inhibits lipolysis and therefore release of free fatty acids into the blood. It inhibits the release of glucagon from pancreatic alpha cells, which usually has the opposite action, as I mentioned. Glucagon usually promotes glycogenolysis and gluconeogenesis in the liver and promotes lipolysis in the adipose tissue, and causes the release of free fatty acids into the blood. So in diabetes, we have insulin deficiency or insulin resistance. In that setting, serum glucose rises after a meal, but peripheral tissues like skeletal muscle and adipose tissue struggle to take up the glucose in the blood because there's no insulin to facilitate that. And so the peripheral tissues become starved of glucose. In the absence of any inhibition from insulin, pancreatic alpha cells will start to release massive amounts of glucagon into the blood, which will then stimulate the liver to undergo glycogenolysis and gluconeogenesis. So further elevating the serum glucose, promoting hyperglycemia. It will also stimulate adipose tissue to undergo lipolysis, which then results in the release of large amounts of free fatty acid into the blood. And these free fatty acids then go to the liver and get oxidized into ketones, resulting in increased serum ketones. So therefore, DKA is usually accompanied by hyperglycemia. And the use of Sglt2 inhibitors puts patients at risk of euglycemic DKA because Sglt2 inhibitors promote glycosuria, which normalizes the serum glucose. So you can get patients who are on Sglt2 inhibitors present with significantly elevated ketones, but still be relatively normoglycemic or only have borderline elevated glycemia. Because Sglt2 inhibitors promote renal loss of glucose. So Sglt2 inhibitor-induced euglycemic DKA presents in much the same way as usual DKA, except serum glucose is normal. So patients present with usually quite an acute onset of abdominal pain, nausea, vomiting, and fatigue and obtundation. If they get admitted to ED, if you perform a finger prick ketone level, you'll find that it's elevated, usually above 1.5. If you perform a blood gas, you'll find that the patient has metabolic acidosis, or specifically, high anion gap metabolic acidosis. So would show a low pH, normal CO2, and classically low serum bicarbonate, suggesting inadequate respiratory compensation. Now, I might hit pause there. So there are, to my understanding, 4 main causes of high anion gap metabolic acidosis. So whenever you see metabolic acidosis associated with a wide anion gap on ABG or VBG, there are 4 things that you should look for as to what can cause it. Can someone suggest some causes of high anion gap metabolic acidosis or HAGMA? Shen, can you explain what mud piles is?
I'm not sure about the 4 classical causes, but there's an acronym for increased anion gap metabolic acidosis. Like M is for methanol, and U is uremia, and B is just diabetic ketoacidosis, and P is paracetamol or acetaminophen intoxication, and I is I think it's isoniazide or something, and L is just lactic acidosis, and D is ethanol, and S is sorry, couldn't remember the S cause.
Yeah, actually, that covers the 4. I probably just reclassified it. I think Shan has read my mind. So high anion gap metabolic acidosis, 4 causes that I think of. So first, lactate, that's causing the acidosis. Secondly, ketones, that's causing the acidosis. Thirdly, toxins or poisons. So ethanol can do it, methanol can do it, salicylic acid can do it. Ethylene glycol can do it. So I classify them under toxins or poisons. Or fourthly, renal failure. So if you see an ABG showing high anion gap acidosis, think 4 things: lactate. So is the patient presenting with ischemia, causing release of lactic acid into the blood? Ketones, is the patient presenting in DKA? Poisons, has the patient ingested ethanol or methanol? Or 4, is the patient uremic from renal failure? So 4 causes. Now, treatment of DKA, so 3 components. So patients with DKA have glycosuria due to either significant hyperglycemia, which is the garden variety DKA, or if the patient is on Sglt2 inhibitors. Sglt2 inhibitors also promote glycosuria as well. Now, glycosuria results in osmotic diuresis, which results in polyuria, which results in significant dehydration. So fluid deficit in adults with DKA is generally at least, up to 3.5 liters and can be up to 7 liters. So aggressive IV fluid replacement is essential. So that's the first component of treatment of DKA. Second component, so patients with DKA are insulin deficient. So you need to give them insulin, IV insulin. So as you know, insulin results in a shift of potassium inside of cells. So it's essential to ensure that the potassium concentration is above 3.5, so it's normal, before IV insulin is commenced. So insulin will gradually, decrease the BSLs, and it's standard protocol. Once the BSLs, you serially monitor the BSLs as you're giving this IV insulin infusion. And once the BSLs drop below 15, you start them on IV glucose. So IV glucose and IV insulin. And the goal is to continue IV insulin and IV glucose until the anion gap normalizes and the bicarbonate normalizes as well. So that's the second component of DKA therapy. And the third component is that in patients with DKA, the total body potassium is depleted from the osmotic diuresis as well. So osmotic diuresis caused by glycosuria draws not only water, but also electrolytes into the urine. So you pee out a lot of potassium as well. So the total body potassium is almost invariably depleted in DKA. And this is despite initial serum potassium perhaps being normal or elevated in the setting of metabolic acidosis. So as you probably remember, in a state of acidosis in the kidneys will try to throw out protons in exchange for potassium. So potassium is usually elevated in the context of metabolic acidosis, but overall in DKA the total body potassium is depleted. So you need to make sure to replace IV potassium and ensure that the serum potassium is maintained in the normal range. So three components to DKA treatment: aggressive IV fluid replacement, insulin, and once the BSL drops below 15, starting glucose infusion until the bicarbonate and the anion gap normalizes, and then thirdly, replacing the potassium because they're invariably potassium deplete. So that's all I want to say about euglycemic DKA. So a quick word about spontaneous bacterial peritonitis, which is the other differential that I mentioned. So it's defined as an infection of a pre-existing acidic fluid without evidence of an intra-abdominal secondary source. Like, obviously if you perforate your bowel, for instance, then yes, bacteria can get into the peritoneum and cause a peritonitis. But what we're saying is that there's no secondary source, there's no perforated viscus, but there's still bacteria in the acidic fluid. That's what we define as spontaneous bacterial peritonitis, as opposed to secondary bacterial peritonitis, which is a bit confusing. So spontaneous bacterial peritonitis is almost always seen in the setting of end-stage liver disease. So most of the cases are due to gut bacteria, even in the absence of gut perforation. So organisms like E. coli, Klebsiella, or your gram-negatives, although gram-positive infections can occur as well. So occasionally you can get streptococcal and staphylococcal infections causing SBP. So SBP classically presents with a triad of fever, abdominal pain, altered mental status. So it's a differential that we need to entertain in a cirrhotic patient like ours. And if the way to diagnose SBP, if you're concerned about SBP, the first line investigation is an acidic tap. And I have a picture of, I don't know if anyone here has seen an acidic tap performed on the ward before, but I have a diagram depicting that. So you do an acidic tap. You aspirate a bit of acidic fluid, and then you send it to be tested. And there are a couple of things that you that you test it for. So you put some of the acidic fluid into blood culture bottles, so aerobic and anaerobic bottles, to see if you can grow organisms. You also do a cell count on it. You do a gram stain looking for, again, organisms, and you can do some fancy acidic fluid chemistries as well, looking for things like albumin, protein, glucose, lactate dehydrogenase, amylase, bilirubin, et cetera, et cetera. Now, the diagnosis of SBP is made if the neutrophil count in the acidic fluid is above 250 cells. Or the culture results, so in the blood culture bottles, come back positive for any organism, and secondary causes of peritonitis, such as a perforated viscus, are excluded. So the treatment of SBP, like DKA, consists of 3 components. So the first is that so in patients with SBP, if they're on a non-selective beta blocker, which a lot of cirrhotic patients are on, you need to discontinue that permanently, because it's been convincingly shown that non-selective beta blockers increase rates of hepatorenal syndrome, so throw patients into renal failure, and are associated with more days of hospitalization. If the patient gets a liver transplant, decreased transplant-free survival is just associated with badness in the setting of SBP. So you discontinue that, strike that off the medication chart permanently. The second component is that obviously, you have an infection, usually a gram-negative rod infection in the acidic fluid. So you start, you do the acidic tap first, and then start the patient on usually a 3rd-generation cephalosporin that has both good gut coverage of things like E. coli and Klebsiella, and also is able to achieve good acidic fluid levels as well. And usually the treatment that we put patients on is IV cefotaxime. So the third component is that, so we talked about hepatorenal syndrome. So renal failure secondary to hepatorenal syndrome develops in about 30 to 40% of patients with spontaneous bacterial peritonitis, and is a major cause of death in patients with cirrhosis. It's been shown that the risk of renal failure in this setting can be decreased with infusion of IV albumin. So three components to treatment of SBP. Obviously, you want to start patients on antibiotics, usually cefotaxime. You want to stop non-selective beta blockers because it signals badness in SBP. And thirdly, you want to start patients on an IV albumin infusion because it's been shown to decrease the risk of renal failure. And lastly, I want to talk a bit about laparoscopic adjustable gastric banding. So this, you won't see this being done on patients that much anymore. But you'll see, patients who have had this procedure done, 10, 15 years ago, and present with complications from their adjustable gastric banding. So it's useful to know a bit about it. So it's a rather outdated bariatric procedure performed for management of severe obesity. It's a purely restrictive procedure. And as you can see in the diagram, it compartmentalizes the upper stomach by placing a tight adjustable prosthetic band around the entrance of the stomach, so as to restrict sort of food intake, and it treats obesity that way. As I mentioned, it's largely fallen out of favor, gradually, being replaced by other procedures, especially things like sleeve gastrectomy and things like Roux-en-Y gastric bypasses, which I'll talk a little bit about later on in this talk. It's been shown that sleeve gastrectomy and Roux-en-Ys have much better results than gastric banding, and have less complications. So gastric banding isn't really done anymore. So the gastric band itself consists of a soft silicon ring that's connected to an infusion port that's embedded in the subcutaneous tissue, usually in either the left upper quadrant or the right upper quadrant. And you can adjust how tight the band is just quite easily by using a syringe and needle. So you don't need to open up the patient again in theatre. You can do this on the ward. If a patient presents with too tight of a gastric band and is complaining of dysphagia or worsening GORD, you can get a syringe and a needle, stick it in the infusion port, which is situated just underneath the subcutaneous tissue, and then draw out a bit of fluid. So release it a little bit. If you want it tighter, you can inject more fluid into it. And so it's quite easily adjustable in that way. There are quite a number of complications that can arise from this gastric banding procedure. And I've listed some of them on the slide there. So slippage, the port can get infected, band erosion, pouch dilation can cause persistent GORD, as I said, if it's too tight. So all of those complications can cause abdominal pain. So it's something that we need to consider in this particular patient. So let's go back to the case itself. With all of these differentials in mind, you then go and see the patient to find out a little more about her presenting complaint. And this is what she tells you. So she tells you that, yesterday evening, she felt a stabbing pain first in the left upper quadrant while watching TV before dinner. And then over minutes to hours, the pain evolved into a band-like pattern across the upper abdomen, associated with a nausea, but she's never vomited. She's otherwise been eating and drinking normally. She hasn't had any suspicious foods, denies any fevers, chills, or sweats, no diarrhea or constipation. She says that her bowels last opened yesterday and that they were normal. She's not complaining of any urinary symptoms. There's a recent weight gain of 4 to 5 kilograms over the past year, which is neither here nor there. The current pain is, relatively tolerable at 4 out of 10. She tells you that the lap band procedure was performed, many years ago in 2007 at an external hospital. As I said, this is an outdated procedure. So often the operation happened, 10, 15 years ago. And she last had a gastroscope 1.5 years ago in the setting of unexplained vomiting, which showed delayed gastric emptying. And she was told by the gastroenterologist that was treating her at the time that there was nothing that they could do and no interventions that they could offer for delayed gastric emptying. So, okay, given this history, does this change your list of differentials? Any other questions that you might ask? Oh, and she hasn't had her AstraZeneca, even her first dose of AstraZeneca. So we can rule out vaccine-induced thrombotic thrombocytopenia. Sad, yeah. Right. So you proceed to examine her. Her ob's stable. She's afebrile. She looks well. She's obese, suggesting that the gastric banding procedure didn't actually work. She has a palpable scar tissue on the right upper quadrant, probably from the lap banding procedure. She has a palpable infusion port. You can't see it, but it's, you can feel it under the skin in the left upper quadrant. You palpate her abdomen. The lower abdomen is fine, but the upper abdomen is diffusely tender to palpation. There's no percussion tenderness, no rebound tenderness. And importantly, shifting dullness is negative. So she's not acidic. So, all right. So you've taken a history, you've done an examination. You're the ED doctor. The next step would be to order some investigations to find out what the hell is going on. Obviously you'll order, basic bloods, FBE, UEC, CRP, et cetera. Any, additional investigations on top of basic bloods that you might suggest we order to figure out what's going on? Lipase, fantastic. Yeah. Lactate. So lactate, absolutely. So lactate we would get on. So you can't actually order lactate, but you do a VBG and or an ABG if you're particularly keen, and it will show you the lactate there. Fantastic. And the VBG will also show whether she's in metabolic acidosis as well from DKA. Yeah, CRP, ESR, fantastic. LFT and coags, yeah, I classify them under basic bloods. Any special fancy ones that you guys want to order? You can even go beyond bloods, go to imaging as well. Chest X-ray to look for perforation, yep, gas under the diaphragm. CT abdo, yep, great. Right upper quadrant ultrasound, so a liver ultrasound. Yeah, FibroScan, yeah. So FibroScan will really, or is a watered down version of a liver ultrasound. It will tell you, that there's fibrosis in the liver, but cirrhosis itself doesn't actually cause abdominal pain. It's really complications of cirrhosis that cause it. All right, cool. Let's see what the bloods show. So, all right, there's little laboratory evidence of an infection or inflammation. CRP is ever so slightly elevated at 5.4, and I'm not too excited about that. LFTs are very mildly deranged. You might think that there's you might say that there's a slight cholestatic predominance, but really it's diffusely deranged. But importantly, the bilirubin isn't elevated, albumin isn't low. We did a lipase, which is elevated. Okay, what do you guys think? Do these blood results change your yeah, very well observed, Sean. Not ridiculously high. Absolutely. So yeah, we often associate elevated serum lipase with pancreatitis, but it's not specific for acute pancreatitis. And in acute pancreatitis, usually the lipase is 3 times above the upper limit of normal. Now the upper limit of normal is 78. 140 isn't actually that elevated. I mean, acute pancreatitis, the patient won't be presenting with 4 out of 10 pain and look clinically well on examination. They will be a lot sicker than that. So you might be thinking, acute pancreatitis, but I think acute pancreatitis is probably unlikely in this case. So cholestatic pattern likely to be biliary tree problem. Remember that this patient had a cholecystectomy. Yeah, cholangitis, but from what I mean, it's impossible for this patient to form gallstones because she doesn't actually have a gallbladder. Likely to be, yeah. Can diabetes cause elevated lipase or the ketoacidosis? I don't think so. So yeah, it's a good thought. DKA could still be on the list of differentials. I can tell you that her BSLs were normal, and I didn't actually include. I should have included the VBG results. The VBG results were unremarkable as well. She wasn't in lactate wasn't elevated. She was not in metabolic acidosis. I should have also included the bedside finger prick ketone results, which were normal as well. So she's not in DKA. Yeah. Not a dumb question, Sean. I actually don't know the answer to that. Sorry, I'm not a budding surgeon, but something for me to read up on afterwards. But yeah, so I think the take-home point for all of this is that elevated serum lipase is not specific for acute pancreatitis. And acute pancreatitis is usually associated with significantly elevated serum lipase. So in the thousands, 2,000. I've seen a patient with serum lipase of 3,000 present with acute pancreatitis. So 140 is not very non-specific. Someone suggested, so those were the bloods that were ordered. Someone suggested, so the next investigation that I will probably order is a CT abdo-pelvis to really look at what's going on. I wouldn't fluff around with an ultrasound of the liver. You know, I'm not highly suspicious that this is coming from the liver. And ultrasound of the liver will just show a cirrhotic liver. It might not show anything more than that. But this was the CT abdo-pelvis report. They noted the lap banding. And there's some wall thickening in the region of the lap band, which they think may represent gastritis. But remember, this is just a black and white image in the setting of a contrast enhanced CTAP. But there's no free retroperitoneal gas, so we're not concerned about perforation. You know, incidental finding of diverticulosis, but losis is, you know, a lot of people have losis. So losis is just the presence of these outpouchings of the sigmoid colon, but it's not infected. And, you know, diverticulitis doesn't really present with upper abdominal pain anyway. Liver is normal. Pancreas is normal. So as we suspected, you know, this isn't really pancreatitis. There's no CT evidence of appendicitis, not that we were thinking about appendicitis anyway. And you know, there's no renal calculus and no hydroureter hydronephrosis. So this isn't a recurrence of nephrolithiasis. And there's no evidence of thrombosis as well. So we can you know, rule out things like Budd-Chiari and portal vein thrombosis, etc. So, you know, this is going, so what happened to this patient? So you know, that's the thing with ED. So you come up with a provisional diagnosis, you then, you know, refer the patient to the appropriate team, and the you know, patient then goes up, becomes admitted under the appropriate unit for definitive management. You're never really in ED involved in a definitive management. So, you know, appropriately, the patient, after discussion with your consultant, you refer this patient to the general surgical unit. The general surgical registrar came round to ED, reviewed the patient, you know, thought that, you know, a tight lap band could potentially be you know, exacerbating the patient's or precipitating the patient's symptoms. So you know, stuck a needle in and removed 7.5 mils from the lap band. So released it a little bit. And they documented the following recommendation. So admission to the general surgical unit, patient can eat and drink, you know, indicating that the patient doesn't necessarily need surgery. They started the patient on some PBIs, some analgesia as required, and if the patient vomits, you know, because, you know, there's the lap band present at high risk of, you know, aspiration. So, you know, yeah, and causing a chemical pneumonitis. So suggested an NGT and to notify the home team if that happens. So afterwards, the patient got admitted to general surgery. The general surgical team then, you know, discussed the patient with the hepatobiliary team, who recommended a gastroscope, because, I mean, you know, on CT AP there was some gastritis, but you can't really see gastritis on CTAP to really visualize gastritis. You need a gastroscope. And so the patient had a gastroscope, no evidence of band slippage or band erosion, and no sort of you know, large pouch above the band. So there's no real complications per se from the lap banding. So there's some resistance during the passage of the scope through the band. So they released it a little more, so a total of 8.5 mils. And there's mild gastritis that was noted, but the pylorus remained patent. There's no stenosis or stricture at the pylorus, normal duodenum, and they took some biopsies as well. So what happened to the patient? Well, the patient's pain resolved during the admission. Patient was subsequently discharged home. General surgery said that they would chase the biopsy results and contact the patient if further action was required. They increased the patient's PPI to 20 milligrams BD. Now, I think general surgeons like PPI for a variety of reasons. I think people who come from more of a medical background are likely to be more reserved about willy-nilly increasing the patient's PPI. Can someone, so does anyone know of any sort of, adverse effects of long-term PPI that medics might be concerned about? Putting patients on high-dose PPI for a long period of time, not H. pylori per se. Yeah, so it causes B12 deficiency. That's one. Because PPIs decrease gastric acid secretion. And acid sort of facilitates vitamin B12 absorption. So if you lose the acid, that decreases absorption of vitamin B12. So vitamin B12 deficiency is a complication. It's for some reason associated with increased risk of C. diff. That's true. And I think the third and the big one that will be drilled into you when you do a rotation through general medicine is that it can cause hypomagnesemia. So it can drop quite rapidly your magnesium levels. And the mechanism is, again, similar to B12, because you have less acid, and acid facilitates absorption of magnesium. PPIs then cause malabsorption of magnesium, and then the hypomagnesemia can then, when it's bad enough, can cause parathyroid hormone resistance, or if it's very, very low, can cause decreased parathyroid secretion. So it can cause a secondary hypocalcemia as well, which can be quite dangerous. So if patients are on PPI, it's important to monitor their B12 and magnesium levels, because both of them can drop quite rapidly. So medics are usually a little more cautious about PPIs. There's a plan to follow for the GP to follow patient in a week to ensure that the symptoms resolved. And quite pertinently, the patient was referred to the bariatric unit for consideration of a revision of the gastric banding, because it's obviously not successful in causing weight loss, and it's causing some complications as well, to revise it to a Roux-en-Y bypass. So I've illustrated a Roux-en-Y bypass, on the right, but it involves sort of, getting the, taking away the gastric band, and then dividing and separating the gastric pouch, which originally sat above the adjustable gastric band, from the distal stomach, and then anastomosing it to the jejunum. And so in this way, sort of food bypasses the majority of the stomach and also the duodenum and goes directly into the jejunum. But the secretions are still allowed to flow. So secretions from the gastric to what's left of the stomach, the liver and the pancreas, are still allowed to flow into the jejunum to facilitate digestion and absorption. And Roux-en-Y, as I mentioned before, like sleeve gastrectomy, has a much higher success rate as a bariatric procedure than gastric banding. And then the patient's getting followed up by her private gastroenterology doctor as well. So that's the first case. So a few learning points there. So what are the 3 Sglt2 inhibitors currently available on the PBS in Australia? Feel free to just type away and use the chat function. So 3 of them, dapagliflozin and empagliflozin, are probably the 2 that you will see most commonly, but there's also a third one, atugliflozin, as well. What are the 3 main side effects of Sglt2 inhibitors? We talked about how glycosuria can predispose patients to UTIs and vulvovaginal candidiasis. It can cause dehydration, resulting in things like orthostatic hypertension and AKI as well. But most importantly, it causes euglycemic ketoacidosis. 4 causes of high anion gap metabolic acidosis. So just discussed this. Lactate, ketones, toxins, and also renal failure. 3 components to the treatment of DKA. So aggressive fluid replacement, IV insulin, and once the BSLs drop below 15, to give them dextrose as well, or glucose. And you need to replace potassium because they're invariably potassium deplete. Most common microbiological causes of spontaneous bacterial peritonitis, usually gut bacteria, so things like E. coli, Klebsiella. How do you diagnose SBP? Usually on acidic tap. You aspirate some fluid, you put them in blood culture bottles, preferably before you commence the patient on antibiotic therapy. And you also do a cell count, gram stain, et cetera, and you need at least 250 neutrophils and culture bottles to be positive. And also you need to have excluded other secondary causes of peritonitis like bowel perforation before you can diagnose SBP. Adverse effects of long-term PPI use and Roux-en-Y we just discussed. Great. So the next patient that your consultant assigns you is Mr. OP. So Mr. OP is a 26-year-old male presenting with a 2-day history of left-sided pleuritic chest pain and dyspnea. Again, another, stock standard presentation that you'll see again and again and again in the emergency department. This patient has no significant past medical history, he's on no regular medications. He's from home with his wife and a young child, works as a carpenter, not a smoker, occasionally drinks some alcohol, and has no recreational drug use. So I mean, just thinking about that, lots of potential differentials. Pleuritic chest pain, could this be lung related? Could this be heart related? Need to exclude things like PE, pneumothorax, to exclude things like AMI, pneumonia, et cetera. Just by a quick chart review, obviously you should be thinking about the serious causes and the common causes, but really hard to pinpoint an actual diagnosis. You go ahead and you speak to Mr. OP. He's been experiencing left-sided pleuritic chest pain and associated shortness of breath for 2 days now. The chest pain is now resolved, but the shortness of breath is still there. He's had an intermittent dry cough. That's now resolved. Is mild nausea, but no vomiting. There's no abdominal pain, no fevers, chills, or shakes. Had a COVID swab last week, which was negative. No recent travel because of COVID. And he gives you a history, so a 2-week history of increasing lethargy coinciding with the start of the COVID-19 lockdown. He also describes these tingling sensations in the fingers and toes and reports legs feeling jelly-like, patient's own words. There's also no heat intolerance, diarrhea, or diaphoresis to suggest a thyroid issue. What do we think? Any thoughts as to what this could be? Yep. Anxiety related. Yep. Yeah, we're thinking functional. Oh, malignancy. Sybil, can you talk through that? Why do you think malignancy?
I'm not sure. Just thinking about the lethargy and the pleurisy chest pain.
Yeah, yeah.
Yeah.
No reported unexplained weight loss. No night sweats. Yeah, they bring home. Yeah, it could be just an upper respiratory tract infection. But overall, we're not too concerned. Yeah, could be pericarditis. I mean, I didn't put down whether the patient had their COVID vaccine or not. I'm not sure you guys are aware, but there's now a signal for pericarditis and myocarditis in people who receive Pfizer. But yeah, so overall, it seems that people, overall as a group, we don't think that this amounts to anything, not too serious, right? Obviously, we're probably, we'll probably be negligent not to do any investigations prior to discharge. So, what kind of investigations would you do on this patient? Yeah, chest X-ray, cool. Yeah. ECG, yeah, we want to, really rule out, an AMI, chest X-ray, bloods. Would you do another COVID swab? Yeah, I mean, last COVID swab was last week. For all we know, she could have COVID. Chest X-ray, basic bloods, ECG, D-dimer to rule out PE. Fantastic. All right. Let's look at what bloods we ordered. It's a bit interesting. So the patient is mildly neutropenic and has mild lymphocytosis. The blood film is a bit interesting as well. Several reactive forms, including rare lymphoplasmacytoid forms. White cell morphology is favored to be reactive secondary to viral infection or inflammation, although occult lymphoproliferative disorder cannot be entirely excluded. So Sybil might be on the money. So electrolytes are not too exciting. There's a bit of transaminitis, but bilirubin is normal, albumin is normal. CRP is not interestingly elevated. We did serial troponins, so they're fine. But D-dimer is 7, which is incredibly elevated. Thoughts? Are you going to send this patient home? Nope. CTPA? Yeah. Great. So yeah, you would, with that kind of D-dimer, I mean, elevated D-dimer is not, as I'm sure you guys are aware, elevated D-dimer is not specific at all to PE. I mean, any inflammatory state, any infection can cause elevated D-dimer. So yeah, Sean read my mind again. So I mean, yeah, we get excited about, elevated D-dimer, but I think given the clinical presentation, I mean, it's not impossible that the patient has PE, but you need to put a question mark on elevated D-dimer. It doesn't actually, it's not diagnostic of PE. But I think we'll be negligent to send this patient home without having done a CTPA. But first, I think, routinely we would order a chest X-ray on this patient, as many of you guys suggested. Yeah, it's not too exciting. And when we follow up with a CTPA, no PE, small focus of bronchiolectasis. within the medial right lower middle lobe. Couldn't really see anything on chest X-ray, but sure, they think that it could be related to a previous infection. No pleural effusion. All right. What do we think? Do we need to admit this patient? If so, under what unit will we admit this patient, or are we happy to send this patient home? HRCT. Yeah, absolutely. You would call him for advice about the blood film, because, you know, lab hematology registrar has gone to the effort of looking down the microscope at the blood film, and he is sort of thinking, the change is probably consistent with a viral infection, but cannot rule out an lymphoproliferative disorder. So again, you'll be negligent not to call him. Yeah, follow up with the GP. Cool. HRCT Shen, what are you looking for there? Yeah. Yeah. I mean, we could perform a CT chest to more definitively characterize the bronchiolectasis. But I mean, it could be causing the symptoms. But all right, let's see what we did. So, we were initially going to discharge this patient, but patient, came back with a significantly elevated D dimer. We did a CTPA, and it didn't really show a PE, but showed some, non-specific bronchiolectasis that, doesn't, in the context of things, isn't that concerning. Didn't show any gross abnormalities on chest X-ray. So the patient ended up getting transferred to short stay unit for a period of observation, and then discharged home with outpatient hematology follow-up. So we called hematology, and they think that they thought that it could be EBV infection, especially in a young guy like him, although it was a little atypical for a standard garden variety EBV infection. But they thought it significant enough to warrant an outpatient hematology clinic follow-up in 2 weeks. But yeah, so they were happy for us to send the patient home. So we sent the patient home. But then on discharge, the patient felt, weak all over. He was able to walk, but we wrote it off really to just a viral infection. Obviously you would feel a bit of lethargy and feel a bit weak. But then the patient went home, represented 1 day later with increasing weakness, and now he's unable to stand or mobilize. He said, so there was initial, if you remember, he initially reported some tingling in the fingers and toes, and that's now progressed to involve the entirety of the hands and feet. He's not had any further episodes of chest pain or SOB. And I think Joshua takes home the gold medal. I think GBS is probably the first, second, and third, differential that you want to consider in a patient who was feeling a bit unwell for 2 weeks and then presents with this progressive, weakness to the point that he's unable to stand. So on his second presentation, we referred this patient to neurology for possible Guillain-Barré syndrome. The patient was seen by the neurology registrar, who agreed with our impression that this was likely Guillain-Barré syndrome, and recommended us admit the patient to neurology and monitor the patient's respiratory function with forced vital capacities every 2 hours overnight. and then the neurology team will see the patient on ward round in the morning. So a quick word about Guillain-Barré syndrome. So I'm not sure if this is a patient, this is a condition that you guys have seen on the ward before. So it's an acute immune-mediated polyneuropathy, typically provoked by a preceding infection, most commonly Campylobacter jejuni, but it could also be precipitated by other infections, including EBV as well. So we think in this patient, he might have had EBV reactivation, and that could have precipitated the Guillain-Barré syndrome. So what happens is that, there's an infection, usually a viral infection. The body mounts an immune response against the infection. The antibodies that are mounted against the infection then subsequently cross-react with peripheral nerve components because of molecular mimicry. So the immune response can be directed towards the myelin of the peripheral nerve, resulting in demyelinating forms of GBS. And the main demyelinating form of GBS is a condition called acute inflammatory demyelinating polyneuropathy, or AIDP. Or the immune response can be directed against the axon of the peripheral nerve, so resulting in axonal forms of GBS. And the two most common axonal forms of GBS are acute motor axonal neuropathy, or AMAN, and acute motor and sensory axonal neuropathy, or AMSAN. So, it's usually triggered by infection. A small percentage of patients develop GBS after, some other triggering event. And as I mentioned earlier, a hot topic at the moment is the potential association between before I talked about the relationship between Pfizer and myocarditis and pericarditis. You may be aware, so adenovirus vectored COVID-19 vaccines, so AstraZeneca or Johnson & Johnson, has been associated with, VIPIT, so vaccine-induced immune thrombocytopenia. But the other thing that they think is, a signal is now emerging for is Guillain-Barré syndrome. As far as I'm concerned, two safety concerns with the AstraZeneca vaccine. One is VIPIT, so vaccine-induced immune thrombotic thrombocytopenia, and the second is potentially precipitating Guillain-Barré syndrome. And one safety concern with Pfizer, which is, myocarditis and pericarditis. But these are very, very rare safety events. Now, historically, Guillain-Barré syndrome was considered a single disorder, but it's now recognized as quite a heterogeneous syndrome with several variant forms. So I think what you need to know is that, so there's one main demyelinating form, which is AIDP, and there's two main axonal forms, which are AMAN and AMSAN. So talking first about AIDP. So AIDP is the most common form in Australia, and indeed in the US and Europe. It accounts for about 90% of cases of GBS. And so as I mentioned before, in AIDP, the immune response is directed towards the myelin of the peripheral nerve and causes a demyelinating form of GBS. The typical features are what this patient presented with. So progressive, fairly symmetric muscle weakness, accompanied by absent or decreased deep tendon reflexes. And so I forgot to include the examination findings, but his deep tendon reflexes bilaterally could not be elicited. So that's the classic presentation. 90% of cases present like that. Now, moving on to the two axonal forms. So AMAN and AMSAN, so they're the two primary axonal forms of GBS. Here, the immune response is directed towards the axon, not the myelin, so the axon of the peripheral nerve. And AMAN and AMSAN are both more common in Asia. So they're relatively rare in Australia and in the US and Europe. the difference between AMAN and AMSAN is essentially in the name. So in AMAN, only motor nerves are affected, whereas in AMSAN, AMSAN is a more severe variant where both the motor and the sensory nerves are affected. So there's one other clinical variant which is associated with an eye muscle predominance. So it's called Miller-Fisher syndrome. It accounts for about 10% of cases in Australia. So it classically presents with a triad of ophthalmoplegia, ataxia, and areflexia. So ophthalmoplegia, ataxia, and areflexia. And the thing about Miller-Fisher syndrome is that there's a blood test that is quite specific for Miller-Fisher syndrome. So Miller-Fisher syndrome is usually associated with antibodies against a ganglioside component of the nerve called GQ1B. So you can do a serum GQ1B antibody test, and if that's positive, that pretty much clinches the diagnosis of Miller-Fisher syndrome. So GQ1B is strongly associated with ocular motor nerves, which is why Miller-Fisher syndrome has eye predominance. So those are the most common variants of Guillain-Barré syndrome. Now, to diagnose, so we suspect, we and the neurology registrar suspect a diagnosis of Guillain-Barré syndrome in this patient, and the clinical features are quite consistent. Progressive, symmetric muscle weakness, absent depressed deep tendon reflexes. Usually the weakness, begins in the legs and then progresses upwards, but it can, present firstly in the upper limbs. It can present firstly in the face, and there's a whole spectrum of severity. So the weakness can vary from just mild difficulty walking to nearly complete paralysis of all extremities, and the facial muscles, the respiratory muscles, and bulbar muscles as well. It can be a life-threatening condition. Patients also, 80% of patients present with these paresthesias in the hand and feet, and certainly our patient presented with that. About 70% of patients present with dysautonomia as well, so a screwed up autonomic nervous system. And this can manifest as diarrhea, constipation. It can manifest as SIADH, so euvolemic hyponatremia. Can cause bradycardia, urinary retention, tachycardia, cardiomyopathy, and even Horner's syndrome as well. So remember the triad of Horner's syndrome, ptosis, meiosis, and hydrosis. So it can cause all of that. So if you suspect GBS in a patient, as we do in this case, you can support your clinical diagnosis by ordering 2 investigations. So I want to know what 2 investigations we order to confirm the diagnosis. So the first one is not an EEG, lumbar puncture. Yeah. And the second one is an EMG or nerve conduction studies. So I'll talk about why lumbar puncture first. Actually, I might put this question to you guys. Do you guys know what we usually see on lumbar puncture in patients with GBS? That's quite specific to GBS. Yep, you won't. I mean, it's not completely acellular, but there's normal CSF white cell count. Fantastic. Yep. Wai Chung is on the money there. So it's something called albuminocytologic dissociation. It's a mouthful. Albuminocytologic dissociation. So albumin and cytology or white cells, the white cell count don't match. So they're dissociated. So what we mean by that is that the CSF protein is elevated, but the CSF white cell count is normal. So usually in meningitis, you would expect both of them to be elevated, but there's a dissociation there. Elevated CSF protein, but normal white cell count, or what we call albuminocytologic dissociation, and that's quite specific for the diagnosis of Guillain-Barré syndrome. So it's thought that it's not an infection per se, so we don't expect the white cell count to be elevated, but the elevated CSF protein is thought to be due to increased permeability of the blood-nerve barrier, caused by often this demyelinating condition. So that's the first investigation that we will order. If we perform a lumbar puncture, we get albuminocytologic dissociation. The next study to order is either an EMG or a nerve conduction study. I mean, this is not necessary for the diagnosis of GBS, but it helps to distinguish between different clinical variants. So in particular, it helps to distinguish between whether this is a demyelinating form of GBS or whether it is an axonal form. So in the demyelinating form, you will see classic features of demyelination on nerve conduction studies. For the axonal forms, you'll see decreased motor and sensory and/or sensory amplitudes. So it's useful to distinguish between the different clinical variants. And as I said before, Miller-Fisher syndrome, so the I one. So there's an antibody test for it called GQ1B. And if that's positive, that clinches the diagnosis of Miller-Fisher syndrome. And it's, we know that it's not other variants of GBS. So obviously, GBS, is one thing that we need to consider, but obviously we need to keep our minds broad and think about what other things could be causing his progressive weakness. So other, differentials could be, there are other causes of acute polyneuropathy. So severe thiamine deficiency can cause an acute polyneuropathy. Peripheral nerve vasculitis can cause this kind of acute polyneuropathy. So a thiamine level and a vasculitic screen is also useful in this patient. So spinal cord disorders can sometimes be confused with GBS, since spinal cord disorders can cause depressed or absent reflexes in the acute stage. I mean, on examination, if the patient presents with, bowel or bladder dysfunction and a sensory level, that probably, steers us away from a diagnosis of GBS towards a diagnosis of a spinal cord disorder. And to definitively rule that out, we could order an MRI spine to look for a focal spinal cord lesion. The other thing that could cause is, so are the manifestations symmetrical or asymmetrical? So GBS in the AIDP variant, it's classically symmetrical, not asymmetrical. So asymmetrical would point you to another diagnosis. So the other thing that can cause this kind of presentation is a neuromuscular junction disorders. So there are two but the thing to remember is that this patient also presented with some sensory signs as well, some paresthesias, and usually neuromuscular junction disorders, you just present with weakness, you don't really present with sensory signs. But there are two neuromuscular junction disorders that I want to talk about. One is myasthenia gravis, and the other is Lambert-Eaton syndrome. Now, do you guys know the difference between myasthenia gravis and Lambert-Eaton? Yeah, absolutely. And I think one way to think about it also is that myasthenia gravis is a primary autoimmune disorder, whereas Lambert-Eaton is usually a paraneoplastic syndrome associated, as Hanyu said, associated with cancer, lung cancer, small cell lung cancer. So just a bit of revision. So myasthenia gravis is a primary autoimmune disorder caused by autoantibodies against the postsynaptic acetylcholine receptor in the neuromuscular junction. So that's the predominant antibody. Now, you can also get autoantibodies targeting two other proteins in the neuromuscular junction as well. One is called muscle-specific tyrosine kinase, so MuSK, MuSK. And the third one, which is far less common, is low-density lipoprotein receptor-related protein, so LRP4. So there are three autoantibodies that we test for in myasthenia gravis: the acetylcholine receptor antibodies, the MuSK, so muscle-specific tyrosine kinase, MuSK antibodies, and also occasionally LRP4 autoantibodies as well. Now, the myasthenia gravis, results in muscle weakness that is classically fatigable. So the more you use it, the worse the weakness gets. And it can, so you can get ocular variants of myasthenia gravis that affect only the ocular muscles, causing ptosis or diplopia. But you can also get more generalized myasthenia gravis that affects the bulbar muscles, causing fatigable chewing, the facial muscles, causing classically the myasthenic, what's called the myasthenic sneer. You can get it affecting the muscles in the neck, causing this what they call the dropped head syndrome, and limb muscles, causing the proximal limb weakness as well. And the most dangerous one is when it affects respiratory muscles, and it can cause respiratory failure and even death. Now, in myasthenia gravis, the reason why we're not really concerned about myasthenia gravis in this case is that reflexes are often spared in myasthenia gravis. It's just the weakness. So myasthenia gravis doesn't really explain the areflexia or the decrease deep tendon reflexes in our patient. So as I said, myasthenia gravis, the weakness worsens with muscle use, and myasthenia gravis is associated with a type of benign cancer. You guys know what I'm talking about? Yeah, thymoma. So in all patients with new diagnosis of myasthenia gravis, you need to go looking for thymomas as well. And so the treatment of myasthenia gravis is usually using an acetylcholinesterase inhibitor, most commonly peritostigmine. And peritostigmine, it inhibits acetylcholinesterase, which usually degrades the acetylcholine in the neuromuscular junction. And so it results in increased levels of acetylcholine in the neuromuscular junction that can then bind to the acetylcholine receptor. And you usually can reverse the symptoms with peritostigmine. On the other hand, Lambert-Eaton syndrome is a paraneoplastic syndrome caused by small cell lung cancer. So you get a small cell lung cancer just throwing out these antibodies against, as someone said, presynaptic calcium channels. So not postsynaptic, which is myasthenia gravis, but presynaptic calcium channels. And this results, as you're probably aware from your second year undergrad physiology, presynaptic calcium channels are required for release of acetylcholine into the neuromuscular junction. And so if you have autoantibodies inhibiting presynaptic calcium channels, you don't get release of acetylcholine into the neuromuscular junction. So this means that even if you treat the patient with an acetylcholinesterase inhibitor, well, there's no acetylcholine in the neuromuscular junction anyway, so the symptoms don't improve with an acetylcholinesterase inhibitor. So it has minimal effect. And the weakness in Lambert-Eaton syndrome usually improves with muscle use, in contrast to myasthenia gravis. So they're two quite distinct clinical entities, but important to know the difference. And I think the final differential that we want to bear in mind is this thing called critical illness myopathy or neuropathy, which can occasionally mimic GBS in the sense that it can present as an acute paralysis. But I think in this patient, GBS is probably still the most important diagnosis that we want to investigate for, and the lumbar puncture and the nerve conduction studies will tell us whether it's GBS or not. So that's just a little diagram showing the difference between myasthenia gravis and Lambert-Eaton syndrome. Cool beans. Yeah, so we'll get to treatment in a second. So it is treatable. So yeah, how do we treat GBS? So I think that several components to consider. So we've already, the Reg very rightly pointed out that we should be doing Q2 hourly forced vital capacities to monitor for respiratory depression, because that can be life-threatening. There are three things that we need to monitor for. So we need serial neurologic monitoring. So we need to perform, a neurological exam, every couple of hours, testing muscle strength in all four limbs, facial bulbar, neck strength, and also get a formal speech and swallowing assessment as well, to really sort of monitor whether the GBS is progressing or not. I think most importantly, respiratory monitoring. So serial, rest rate, SATs, forced vital capacities, et cetera, because 10 to 30% of patients develop severe respiratory muscle weakness that requires ventilatory support in GBS. The Q2 hourly forced vital capacity is probably the most important monitoring component. And then obviously hemodynamic monitoring, as I said, it can present with, GBS can present with dysautonomia. And so we need to monitor hemodynamics as well. So GBS is usually a self-limiting condition, but it can, in the process of being self-limiting, it can kill you. So it usually evolves into an idea within 4 weeks before it then suddenly improves. So some patients, you can just monitor them, and if they don't present with, severe or rapidly progressing, muscle weakness or respiratory compromise, then you can just monitor them. But if they do, then they're probably best managed in ICU, because in ICU you can rapidly intubate these patients. Having said all of that, there are 2 treatments that have been shown to shorten the time to recovery in GBS. So one is IVIG, as Shen pointed out. The other is plasma exchange. And I think I've seen more often IVIG being used to treat GBS, and certainly this patient got IVIG as well. So it's usually a couple of weeks of treatment, usually the patient respond quite quickly to the therapy, and then afterwards they need to undergo a period of rehabilitation. So that was the second case. Most commonly, so a couple of learning points there. So most commonly identified precipitant of GBS is a viral infection, usually Campylobacter jejuni, but can be precipitated by EBV, which we think was the case in this patient. Just as an aside, 2 safety concerns with AstraZeneca are the VIPIT, so vaccine-induced immune thrombocytopenia, and Guillain-Barré syndrome as well. And the main safety concern with Pfizer that has been identified at the moment is risk of myocarditis and pericarditis. The most common form of GBS in Australia is AIDP. The 3 other clinical variants are the 2 axonal variants and also Miller-Fisher syndrome, which can be diagnosed on GQ1B antibody testing. Classic finding is this albuminocytologic dissociation. The difference between myasthenia gravis and Lambert-Eaton we just talked about. One thing that we haven't talked about is the antibiotic that is absolutely contraindicated in patients with myasthenia gravis. Do you guys know what that is? There's one antibiotic that you should never put patients on, put patients with myasthenia gravis on. Yeah, there actually have been case reports of fluoroquinolones causing neuromuscular blockade, but the main one is actually aminoglycosides. So gentamicin is the one that's absolutely contraindicated in myasthenia gravis. Anyway, and 2 therapy is IVIG and plasma exchange. So 20 minutes to discuss the last case. So you're nearing the end of your shift. The last patient that your consultant asks you to see is Mr. QR. Now this is a bit of a curveball. So not your garden variety abdominal pain, chest pain, dyspnea, etc. So it's a 64-year-old male that has been referred from the Peter Mac outpatient clinic with quite significant hypokalemia to a K of 2.9. And as you guys are probably aware, K of 2.9 is potentially quite dangerous, can cause cardiac arrhythmias, including things like VT and VF. So this patient was, in the PMAC outpatient clinic doing pre-chemotherapy bloods, and it was incidentally found that he had a K of 2.9. This is on a background of multiple myeloma and primary hyperaldosteronism, which is known to be secondary to bilateral adrenal adenomas. So, quite an interesting past medical history. So multiple myeloma has been exposed to hepatitis B on entecavir for it, has hypertension, has NAFLD with prior liver resection, has had a cholecystectomy, and has proven primary hyperaldosteronism that's secondary to these bilateral adrenal adenomas. He's on some medications. So lenalidomide, dexamethasone, we'll talk about this in more detail in a second, but lenalidomide, dexamethasone. So VRD is part of the VRD therapy, which is the most common treatment regimen for patients with multiple myeloma that aren't on a clinical trial. So on some aspirin, valganciclovir, entecavir, and a combination of amiloride and hydrochlorothiazide, which are two diuretics. Amiloride being your ENaC inhibitor, and hydrochlorothiazide being your thiazide diuretic. So he's from home with wife. It was a former factory worker, but has since retired. He's an active smoker of 25 cigarettes per day, so about 1 pack per day. He doesn't drink much alcohol, doesn't use any recreational drugs. Now, couple of questions before I ask you guys what the hypokalemia could be due to. So this patient has a history of primary hyperaldosteronism secondary to bilateral adrenal adenoma. There's an eponymous name for this. Does anyone know what it is? Con, great, yeah. So it's called Con syndrome. So primary hyperaldosteronism that is caused by an adrenal adenoma is called Con syndrome, because Con is the guy who initially described the case series for these patients. Now, the mechanism is that you had these adrenal adenomas that secrete large amounts of aldosterone into the blood. And if you recall, again, second year undergrad physiology, aldosterone acts on mineralocorticoid receptors inside these special cells called principal cells, or P cells, located in the cortical collecting duct. And its effect is to increase sodium reabsorption and therefore water reabsorption, and also increase potassium secretion as well. So we'll talk more about that. Now, so, and we'll talk about multiple myeloma as well. But I might just ask the question, any theories, any thoughts on what the hypokalemia could be due to? Because I mean, hypokalemia you can easily replace with some IV potassium and oral potassium, but you really want to know what the cause is so that yeah, great. So yeah, hyperaldosteronism can cause low K, renal tubular acidosis from multiple myeloma. Okay. The amiloride, amiloride is a potassium sparing diuretic, but I mean, it's a combination of a potassium sparing diuretic and a potassium wasting diuretic. So one might think that they cancel each other out. There's one other thing. So the obvious one is primary hyperaldosteronism, because aldosterone increases potassium secretion, so you lose potassium renally. But there's one other possibility that we haven't mentioned, Whoa, nice. Dexamethasone, fantastic. So yeah, dexamethasone, it's a corticosteroid. It's not a mineralocorticoid, but as you probably remember from undergrad studies as well, dexamethasone, so corticosteroids can cross-react with mineralocorticoid receptors. So the dexamethasone can, although it's a corticosteroid, can act on mineralocorticoid receptors inside of P cells as well to increase sodium reabsorption and increase potassium secretion as well. The two most likely, culprits are probably, the known primary hyperaldosteronism, and probably exacerbated by the dexamethasone therapy as well. So I said I'll talk quickly about multiple myeloma. Multiple myeloma is a cancer of plasma cells. And if you recall your sort of, pre-clin immunology, the life of a B cell. So the story begins in the bone marrow. So, B cells born in the bone marrow. You have, a hematopoietic stem cell that differentiates into an IgM secreting immature B cell in the bone marrow. And then that immature B cell then migrates to the spleen and matures into a follicular B cell. And then it migrates to the lymph nodes, becomes activated with T follicular helper cell help. And then it proliferates in the lymph node to form this germinal center. We call the B cell then a germinal center B cell. And in the germinal center, the B cell then undergoes somatic hypermutation, class switch recombination, and then finally terminally differentiates into either a memory B cell or a plasma cell. And then the plasma cell then usually travels back to the bone marrow and just chills out in the bone marrow, secreting antibodies into the blood. Now, multiple myeloma is when one of these plasma cells that are just chilling out in the bone marrow becomes neoplastic and begins to divide and proliferate out of control. And the result of that is that this neoplastic plasma cell then starts to secrete large amounts of monoclonal immunoglobulin. And the most common immunoglobulin is of the IgG subtype. So 55% are IgG subtype. About 25% is IgA, very rarely, IgM or any other subtype. So it can secrete sort of monoclonal, like full immunoglobulin, or it can secrete just bits of immunoglobulin. And as you recall, immunoglobulin is made of 2 heavy chains and 2 light chains. And it can also secrete just the light chains, what we call free light chains into the serum. And there's an eponymous name for free light chains as well. Do people know what the eponymous name for free light chains are? Yeah, Bence-Jones proteins. So they're essentially the same thing. Cool. So in terms of presentation, multiple myeloma presents, I'm sure you guys are all aware, presents with CRAB symptoms. So I have, what CRAB stands for listed on the slide. So C stands for hypercalcemia. Biochemically, we define hypercalcemia to be calcium above 2.75. R stands for renal disease. So creatinine clearance less than 40 or creatinine above 177. And that seems arbitrary, but it's converted from the American units. A stands for anemia, so we define that to be below 100 hemoglobin, or at least 20 below normal, the patient's normal. And B stands for bone pain or bone lesions, that's defined radiologically by at least one osteolytic lesion more than 5 millimeters in size on imaging. So I want to talk a bit. So the clinical features are actually, they make sense in the context of the pathophysiology of multiple myeloma. So as I said, multiple myeloma is one plasma cell, usually chilling out in the bone marrow, becoming neoplastic, dividing out of control. So when it divides out of control, it's in the bone. So this forms an osteolytic lesion. And so this causes bone pain. And because it's forming an osteolytic lesion, the bone's getting destroyed, that releases large amounts of calcium into the blood, and that causes hypercalcemia. because you have these neoplastic plasma cells dividing out of control in the bone marrow, the bone marrow is packed full of these neoplastic plasma cells. And so red cells don't actually have room to develop in the bone marrow. So erythropoiesis cannot happen. And so this results in classically a normocytic normochromic anemia. The neoplastic plasma cell also secretes, as I said, it can secrete like full monoclonal immunoglobulins, but it can also secrete just the light chains, or what we call Bence-Jones proteins. And these light chains can then deposit in the kidney, causing a condition called light chain cast nephropathy, or colloquially we call it myeloma kidneys. This is also exacerbated because, as you're probably aware, hypercalcemia can also cause renal damage. So it's really two causes of kidney damage in multiple myeloma. One is the light chain cast nephropathy, and one is the hypercalcemia. And the kidney damage can also, EPO secreted by the kidneys, and so kidney damage can cause a relative EPO deficiency, and that can exacerbate the anemia as well. So it's all linked, and it should make sense in the context of the pathophysiology. So in patients suspected to have multiple myeloma, we perform 2 initial screening tests to determine whether this patient is at a high risk of actually having multiple myeloma or not. Does anyone know what these? They're 2 blood tests that are very easy to do. Do you guys know what 2 blood tests are used for initial screening of multiple myeloma? Fantastic, yeah. So SPEP. So SPEP is usually coupled with immunofixation. So SPEP is I'll talk about the difference in a second, but SPEP, so it stands for serum protein electrophoresis. They run it on a gel, and that shows you proteins in the blood can be divided into a alpha fraction, a beta 1 fraction, a beta 2 fraction, et cetera, and a gamma fraction, which is usually immunoglobulin. And if you run the blood sample on a gel, multiple myeloma, because we're throwing out a lot of immunoglobulin, it will cause a spike in the gamma fraction on the SPEP. But there's also a related test that we do called immunofixation, and immunofixation tells us what the subtype is. So whether we're dealing with an IgG multiple myeloma, or whether we're dealing with an IgA multiple myeloma, or really rarely an IgM multiple myeloma. So the first test is SPEP with immunofixation. It's just a blood test. The second one is serum light chain. Yeah, sure. So Shen, UPEP is also, I'll talk about UPEP in a second, but it's tedious to do. It's not used as an initial screening test because you need to collect the urine for 24 hours, and then you measure you run the urine on a gel to see whether there's a similar spike in the gamma fraction. But you need to wait at least 24 hours. Whereas an SPEP, you can just stab the patient, draw some blood, and send it off. So the second screening test is a serum-free light chain assay. And as you guys can probably remember from your pre-clin immunology, immunoglobulin made up of 2 heavy chains, 2 light chains. The 2 light chains come in 2 varieties. So kappa is the most kappa light chains is the most predominant one, and the other variety is lambda light chains. And so the serum-free light chain assay will give you 3 things. So what the free the kappa light chain concentration is, what the lambda light chain concentration is, and also what the kappa to lambda ratio is. And the normal range is between the 0.26 to 1.65, and anything outside of the range is abnormal and is suspicious for multiple myeloma. So the important thing, and if you ever see, serum-free light chain assays being ordered on patients suspected to have multiple myeloma, and from experience, this is usually patients with renal failure of unclear etiology that also presents with elevated ESR. So a thing to remember is that elevated ESR plus renal failure equals multiple myeloma until proven otherwise. So in these patients, we often do these two screening tests, an SPEP with immunofixation and a serum free light chain assay. It's important that you know roughly how to interpret the free light chain assay, because some people get really excited and really stressed out about individually elevated kappa free light chain and lambda free light chain. So we're not actually interested at all in the kappa light chain concentration or the lambda light chain concentration. They can be elevated in the acute of an intercurrent illness. So inflammation, infection can elevate kappa and lambda light chains because it promotes like an immune response and antibody response. So we don't care. All we care about is actually the ratio from the free light chain assay, because it means that if the ratio is abnormal, it means that there's one rogue plasma cell throwing out one specific monoclonal light chain, either a kappa or a lambda. And that's concerning for a plasma cell dyscrasia like multiple myeloma. So going off what Shen said, so if there are any abnormalities in the two screening tests, we then proceed to do, in addition to things like an FBE to detect anemia, and classically, when you do an FBE, they'll look at the blood film as well. And do people remember what the classic finding on blood film is in patients with multiple myeloma? Yeah, Rulio. So Rulio, it's not specific to multiple myeloma. It just means that there's a lot of proteins in the blood, and that can classically cause Rulio formation. So you'll order an FEE blood film, a UEC to detect the renal impairment, a CMP to detect hypercalcemia. But in addition to those basic bloods, you would do, as Shen said, a 24-hour urine protein electrophoresis, so a UPEP, again with immunofixation. So the UPEP will show an elevated gamma fraction, and then the immunofixation will actually tell you what subtype of immunoglobulin you're dealing with, and that's to detect what so-called Bence-Jones proteinuria. And then often we also do a non-con CT pan scan to look for the extent of bone involvement. And obviously, as with any hematologic malignancy, the ultimate definitive diagnosis rests on bone marrow aspirate and biopsy. So to diagnose multiple myeloma, we need at least 10% clonal plasma cells seen in the bone marrow on bone marrow examination, and the presence of any of the Krabs features. And the Krab features are sometimes called myeloma defining events. Now that's one way. So greater than 10% clonal plasma cells in bone marrow, plus one of the Krab symptoms. A second way to diagnose multiple myeloma is the detection of any one of the four SLIM features. And I'm not sure if you guys have heard of the SLIM features. SLIM features are also called biomarkers of malignancy in the context of multiple myeloma. So it's also an acronym. So S stands for 60. So greater than 60% clonal plasma cells in the bone marrow gives you a diagnosis of multiple myeloma, regardless of whether there are Krab features or not. LI stands for light chain ratio of greater than or equal to 100, which means that the kappa light chain, for example, is 100 times more than the lambda light chain, which is very, very suggestive of multiple myeloma. So if you have a free light chain ratio of above 100, then you can diagnose multiple myeloma regardless of whether the patient has Krabs symptoms or not. And the M stands for MRI. So if you do an MRI scan that shows greater than or equal to one focal lesion, then you can also define multiple myeloma. So two ways to define multiple myeloma: 10% clonal plasma cells on bone marrow plus one of the Krabs symptoms, or regardless of any of that, the presence of one of the four SLIM features. Great. A little bit, I'm not going to talk too much, given the time, about management of multiple myeloma, but I think the three drugs that are commonly used to treat multiple myeloma, which you should know a little bit about, is bortezomib, lenalidomide, and dexamethasone. So dexamethasone, we all know it's a corticosteroid. Does anyone remember or know what bortezomib is? Like what class of agents it is and how it works? So bortezomib is a proteasome inhibitor. Again, this is harking back to some molecular biology from undergrad, but proteasomes, like all cells have proteasomes, and basically when the cell screws up translation and produces a dodgy misfolded protein, all of them get transported to the proteasome and get sheared up. So it's really the waste bin of the proteasome is really the waste bin of the cell, any cell. Now bortezomib inhibits the proteasome, so it results in a buildup of these dodgy misfolded proteins, and that triggers a well-described response called the unfolded protein response, which ultimately leads to cell death. So that's how bortezomib kills the neoplastic plasma cells. It also has a trade name called Velcade. Now lenalidomide, you may or may not have heard of. It's a derivative of a medication which you definitely should have heard of, which is thalidomide. And it sort of has the same side effects as well as thalidomide. So it's teratogenic. We never use lenalidomide in pregnant women because it causes these limb defects, which we call phocomelia. And dexamethasone we already know as well. And there's a whole algorithm that you can use to identify what the first line treatment for multiple myeloma is, which I won't go into. But good to know the three drugs, at least have heard of them, and also talk about the side effects, know a bit about the side effects as well. And when we say VRD, so V stands for Velcade, which is bortezomib, R stands for Revlimid, which is lenalidomide, and D stands for dexamethasone. So VRD, which is what the patient is on, is bortezomib, lenalidomide, and dexamethasone. Cool. And a bit about primary hyperaldosteronism. We sort of talked about this already, but it's just increased aldosterone secretion from the adrenal cortex. And it's important to know because it's often an underdiagnosed secondary cause for hypertension. So, 95% of hypertensive patients are hypertensive because they have essential hypertension. But in the 5% of cases that are secondary, we all know about, things like pheochromocytoma and stuff like that we need to rule out. But primary hyperaldosteronism is something that we need to rule out as well. Now, there are two common causes for primary hyperaldosteronism. So one is adrenal hyperplasia, which bilateral adrenal hyperplasia, which is the most common cause. But in this patient, we don't just have adrenal hyperplasia, we have adrenal adenoma. So an actual benign tumor forming that's secreting aldosterone, and that's what we call Conn syndrome. Now, clinical features, you can probably figure out from the mechanism of aldosterone. So aldosterone binds to P cells in the collecting duct, causes sodium reabsorption and water reabsorption. So it causes hypertension, and it also causes increased potassium secretion as well. So it causes often decreased potassium. There's also this association with increased cardiovascular morbidity and mortality as well, which is why treating primary hyperaldosteronism is so important. I won't go into too much detail about diagnosing primary hyperaldosteronism, but basically, aldosterone secretion is often sort of triggered by either by renin activity. So renin renin is secreted by juxtaglomerular cells of the kidneys, and then it activates the RAS pathway. It results in angiotensin II production, and angiotensin II then acts on the adrenal cortex to cause secretion of aldosterone. In primary hyperaldosteronism, if you suspect a patient might have primary hyperaldosteronism, you would do 2 blood tests. So one is the plasma renin level, and the other is the plasma aldosterone level. And you'll calculate a renin aldosterone ratio. So renin is usually decreased, and aldosterone obviously is increased. So the renin aldosterone ratio will be decreased. So treatment of primary hyperaldosteronism is fairly simple. If it's a bilateral cause, then we treat it using medical therapy. So spironolactone is the first-line agent. And unilateral causes, we just cut it out. So patients presenting with hypo, so you repeat the test, and the potassium is actually more depressed than before. It's now at 2.6. How are you going to treat this patient? So we think that the two major causes that are driving hypokalemia in this particular patient are, one, the known primary hyperaldosteronism. The unfortunate thing is that it's bilateral adrenal adenoma, so we can't really cut out both adrenals. You might remember that this patient was on amiloride and hydrochlorothiazide, which is really second-line agent behind spironolactone as medical therapy for primary aldosteronism. And the second cause is dexamethasone. So this patient has multiple myeloma. Maybe, if the hypokalemia becomes a recurrent issue, we can potentially think about switching the patient from VRD therapy to another therapy. But in terms of underlying causes, we don't have much room to move. So I think the only real thing that we can do in this case is to replace the potassium. And I think important to know, I think this is relatively high yield ways in which you can replace potassium. So there are 2 oral formulations of potassium replacement. Do you guys know the trade names for those 2 forms and the differences between those 2 forms? Sglt2 is one, and as the name suggests, it's slow. And clorvescent, yeah. So clorvescent is the effervescent tablet that you dissolve in water and get patients to drink it. So it's much faster, which is why in a emergency like this, we don't really tend to use Sglt2 because it's pretty shoddy. So we use clorvescent, which is fast. You expect the serum potassium to rise after 2 hours of ingestion. It's very rapidly absorbed, and it provides about 14 millimolars of potassium per tablet. So we can be very liberal in giving this patient, 4 or 6 tablets of clorvescent stat. Sglt2 is it contains less potassium, so it's 8 millimoles rather than 14 millimoles, and it's slow to release because it's enteric coated and has delayed absorption as well. So you expect a serum potassium to rise after 4 hours rather than 2 hours. So it's not as effective as clorvescent and provides less potassium, which is why the go-to is clorvescent. Do you guys know? So when I say clorvescent provides 14 millimoles of potassium per tablet, and Sglt2 provides 8 millimoles of potassium per tablet. Do you guys know what that translates to? What the expected potassium rise would be if you pop a tablet of clorvescent, which contains 14 millimoles of potassium? Yeah, great. So I think what Wei is trying to say, well, Sean said it. So yeah, 10 millimoles, we expect to raise the potassium by 0.1. So one tablet, so 14 millimoles of potassium, we would expect after 2 hours for the potassium to come up to, just above, 0.1. So it's not increased by just above 0.1. So it's actually not that. So feel free to be very, very liberal with how much chlorvescent you give these patients. Do you guys know the side effects of chlorvescent or Sglt2, which patients would routinely complain about? So the one to remember is that it causes GI upset. So it causes nausea, vomiting, diarrhea, abdominal discomfort. Now, as Sean has mentioned. So there are also 2 forms of IV potassium that are available on the ward that you can use. So one is 30 millimoles of potassium in a 1 litre bag of normal saline. So 30 millimoles in 1 litre bag, that gives you a lot of fluid. What we call, so you guys might have heard the term mini bags of potassium being thrown about. So what we mean by mini bag is 10 millimoles of potassium in a 100 ml bag of normal saline. So it's much more concentrated than the 30 millimoles in a 1 litre bag of normal saline. And I think, what's wrong, and it's warranted in this case because the potassium is obviously dropping from 2.9 to 2.6. We want, as Sean mentioned earlier, IV replacement stat. So we will use mini bags, and there are guidelines on how many mini bags to give before rechecking the potassium, which I've included on the slide. 10 millimoles in a 100 ml bag is probably the most concentrated form of potassium you're allowed to give via a peripheral line. You can give more concentrated solutions of potassium, but usually you're not allowed to do that on the ward. You need to transfer the patient to HDE or ICU to get those, and it needs to be through a central line rather than peripheral line. Do you guys know why it's capped at a concentration of 10 millimoles in a 100 ml bag of normal saline, while we don't like to give more concentrated solutions of potassium through a peripheral line? Yeah, not sure if you guys have had IV potassium before, but it kills. It stings really, really bad, and the stinging, the phlebitis that it causes is proportional to the concentration of the infusion. So the first thing that patients will complain about with IV potassium replacement is the stinging when it goes in. That's why we don't infuse more than 10 millimoles in a 100 ml bag via a peripheral line. Great. Okay, so lots of learning points there. So 2 ways to diagnose multiple myeloma: 10% clonal plasma cells plus 1 of the Crab symptoms, or 1 of the 4 SLIM features. VRD stands for bortezomib, lenalidomide, and dexamethasone. Remember that dexamethasone can cross-react, can bind to mineralocorticoid receptors and cause hypokalemia as well. The 2 main causes of primary hyperaldosteronism are bilateral adrenal hyperplasia and adrenal adenomas, or what we call Conn syndrome. If it's bilateral, we need to treat using medical therapy. If it's unilateral, we just cut out the adrenals. What we didn't mention was, why does primary hyperaldosteronism not cause edema? You guys can probably read up about this, but it's the similar mechanism to why SIADH causes euvolemic hyponatremia rather than hypervolemic hyponatremia. So, but basically, it's a phenomenon called the aldosterone escape. You can Google aldosterone escape. So basically, you would expect, aldosterone, it binds to P cells, causes reabsorption of sodium and water. So you would expect the patients to be hypervolemic and be fluid overloaded. But that doesn't actually occur because within days, the patient actually pees it out again. And the reason is that the initial hypervolemic state causes secretion of atrial natriuretic peptide from the atria of the heart. And that causes increased salt and water loss. So the patient, comes back to a euvolemic state. So it's called the aldosterone escape mechanism. The most common causes of hypokalemia, we've talked about two this talk. So corticosteroids can definitely cause hypokalemia. And also, primary hyperaldosteronism can also cause hypokalemia. Covered that. Clinical features we didn't get a chance to talk about, but severe muscle weakness is one. You can present with cardiac arrhythmias, obviously. I think I had a slide on this, but can induce, so hypokalemia can induce renal dysfunction in this syndrome called hypokalemia-induced renal dysfunction. And it also can cause glucose intolerance as well. And the mechanism is similar to how thiazide diuretics can also cause diabetes. So the mechanism is the same as thiazide-induced diabetes mellitus. But I think the important things are two forms of oral potassium are slow K and chlorvescent. Difference between them, one is slow, one is fast. Side effects are GI upset. IV replacement, the main side effects is this stinging, this thrombophlebitis, which is why the maximum concentration is capped at 10 millimoles per 100 milliliters of normal saline. And how much does 10 millimoles of potassium replacement increase serum potassium by? It's 0.1. So sorry for going a bit over time. So that brings us to the end of this talk. Thanks everyone for coming. The next virtual world round is in 2 weeks' time, same time, online. I have a QR code there if you want to sign up now, and it's going to be on stroke. So thanks everyone.